Okay, Debbie, here we have your models all mounted up now.
Okay.
And I'm fairly confident that we've reproduced that relationship that's existing in your mouth now with the appliance, all
Okay.
right? And one of the first things we want to do to verify that is you noted that in your mouth, the first point of contact was that last tooth on the bottom right-hand side, is that correct?
Correct.
And if you look on the articulator here, and I've got what I'm using here, which is a very useful material and equilibrating, and it's 8-micron shim. It's the thinnest stuff that I know of that we can actually, that we know. It's 8-micron shim, it's great material, and what we'll notice here is I have a very solid stop right on the very distal between numbers 2 and 31, and everywhere else here, I mean, there's nothing at all there, okay? So I'm pretty confident that this, and we've taken a couple of bites, as you know already. We've duplicated them, and they've been consistently the same thing. So I'm very confident here now, very comfortable saying that this does in fact represent what's actually going in your mouth. This does represent the relationship between your upper and lower teeth when your jaw joints are in their physiologic position.
Okay.
Now the question becomes one of what can we do about it,
Okay.
And so what are the options for you? And again, needing to keep in mind that one of your goals is to restoratively to fix especially your front teeth.
Correct.
And it might not be a bad idea right now, Terry, if you could kind of maybe zoom in and get a sense of the amount of wear on Debbie's teeth. The models show it very well. As you can see, a lot of wear, especially on the upper incisors, lower incisors also. There's also a significant amount of wear that seems to be both mechanical and evidence of some chemical erosion also. Subsequent or secondary to the mechanical erosion, where we're now getting some of the dentin pits where the enamel's gone through and chemically acid from some citrus beverages or from carbonated beverages and citrus products can cause that secondarily.
Okay.
But the point is, when we talk about what we might be able to do for you, we need to keep in mind really what your goals and aspirations are.
Okay.
And from what you told me to review, you indicated that you want, number one, ideally, to stop clenching or grinding your teeth.
Correct.
I don't know that we can do that. I mean,
Okay.
you know, from my experience in treating you, the fact that you still clenched or ground a little bit with the appliance
Okay.
in, I would give you maybe a little better than 50% chance, 60% chance maybe, that we'll be able to reduce or stop that.
Okay.
I think a better than 50-50 chance, but I wouldn't say by any means for sure that we'd be able to do that.
Okay.
So to do any kind of therapy, and we can really break it down into being reversible or irreversible type of therapy, I think it needs to be based upon what your ultimate goals are.
Okay.
Now, if you had no other aspirations, very simply, if you just want to stop grinding your teeth or stop the damage from grinding your teeth, wearing a night guard appliance might not be a bad option for you, okay?
Okay.
But we still have the situation where ultimately we're going to be doing restorative treatment for your teeth, and do we want to, again, maintain the current bite or do we want to change you?
Okay.
And so if we were to look at what options would be available, and we see that again, that your interference is a posterior interference, and I don't think we need to show this, but there's about 1.5 millimeters slide forward and to the right when we bring the teeth from your first point of contact until everything comes into contact, until you're into what we call maximum intercuspation.
Right.
We really have, and this is, by the way, what we would refer to as occlusal dysfunction. You know, we describe, in my classification system, we describe, first of all, your joints. And we describe your right joint as being a stable joint, the left joint as being a manageably adapted joint. This is, in the occlusal classification system, is what we would refer to as occlusal dysfunction.
Okay.
And that is that you have posterior teeth, back teeth that are in the way of your function.
Okay.
Now, the question becomes one, though, also, however, is that what is causing the problems with you causing you to grind your teeth?
Okay.
And is that causing the wear and tear in your teeth? See, when I see probably the biggest concern that you shared with me and that I have is that wear and tear on the front teeth.
Yes.
And the question is one where, are those concerns, is it because those front teeth are in the way of where you want to function? Or are you in fact functioning or parafunctioning on those teeth because of interferences in the back teeth?
Okay.
And that's an extremely important decision or a very extremely important factor to find out.
Okay.
The reality is that I can tell you that the front teeth aren't in the way of your normal function. And we
Okay.
determine that with the bite registration and the deprogramming.
Right.
The question is, the wear and tear and the damage on your front teeth, the parafunction, the grinding, the clenching, is it a result of your occlusal dysfunction, or is it a result of a central nervous system phenomenon? The reality is, we don't know. The only way we know is to eliminate the occlusal dysfunction. In other
Okay.
words, to eliminate the occlusion puts you into a physiologic occlusion, and we observe.
Okay.
Does it stop? Do you stop grinding or not?
Okay.
My experience in general across the board is about 85 to 90% of the patients that I see who are clenchers or bruxers stop completely.
Okay.
Okay? In your situation, because some of the patterns I see here, I'm not quite as confident as that, but I still, there's probably a better than 50-50 chance.
Okay.
So the question is one where we can go in, we can put an appliance in, into a proper bite relation and see if you clench and grind on that appliance, okay? Conversely, we can go in and we can take a look at this and we'll determine here, right in front of you here, what we can do to your teeth. If we were to do something permanent to actually get your teeth to fit where you physiologically would want to function, to correct your occlusal dysfunction, we really have three options available to us.
Okay.
One is if we can kind of do a reductive reshaping. We call it equilibration. And what that involves doing is essentially, you know, where you're first hitting on these teeth in the back here, we can kind of get rid of the high spots, okay? Eliminate the high spots. And as we go progressively from spot to spot to allow more and more teeth to come together, okay?
Okay.
Secondarily, conversely to that, or opposite to that, we can restore or add on to those spots that aren't in contact.
Okay.
So if you think of your teeth as a set of gears, we can either take away from the high spots or we can add on to the low spots.
To make everything fit.
Exactly,
Okay.
exactly. Or we can orthodontically move them to fit
Okay.
together.
Okay.
Now in reality, what's best for you is, and what we'll typically try to choose, is that path which is going to be the least costly, the least invasive, and basically that's it, okay? And oftentimes to do that, it will involve a combination of options. And looking at you, looking at the amount of adjustment or the amount of error that is here, and the amount of deflection you have, I'm pretty confident that doing a little bit of reductive reshaping may be a part of it. So what I'm going to do here is let's actually go in and see what we can accomplish on these models, because what I would do in these models is essentially going to duplicate what I would do in your mouth, and so we can both kind of understand before we start what we might be able to expect from that, okay?
Okay.